Spine care is not static. It evolves, as our patients do. Scientific Session 5, Caring for the Spine Patient Through Time, focuses on how age, physiology, and life stage shape decision-making across the spine care continuum. From spinal trauma in children and adults to craniocervical junction challenges that change with age, this session addresses the complexities of treating patients over time. We'll examine spinal column shortening in adults and the importance of priming and expectation management as patients become frail, highlighting strategies that balance intervention, outcomes, and quality of life. Through thoughtful discussion and clinical perspective, this session underscores a core goal of the Spine Summit, elevating the quality of spine care for every patient at every stage.
Please welcome moderators Doctors Kai-Ming Fu and Chirag Upadhyaya to the stage.
I'd first like to welcome to the stage Jen Strahle, who will be speaking on spinal trauma in pediatrics and adults.
Good morning. I'm Jen Strahle. I'm one of the pediatric neurosurgeons at WashU in St. Louis, and I'll be talking today about pediatric thoracolumbar spine trauma, really focusing in on the role of bracing and internal fixation with percutaneous pedicle screw placement, and some pediatric-specific factors related to that. And I hope to share maybe one or two new sort of pearls to this room, but I understand that we're sitting in a room of experts right now. So the most common pediatric thoracolumbar fractures that we see typically are chance fractures, which can be bony chance fractures or isolated to soft tissue ligamentous injury, compression fractures, as well as burst fractures from falls, MVC. Pediatric-specific factors in the spine that we consider with treatment include skeletal maturity. Many of our patients are not yet skeletally mature. Many are smaller. Their spines and subsequent bony anatomy is different from adults. A lot of kids are participating in sports, high-level competitive sports, club soccer, basketball, and even if they're not, they're all very excited about their gym classes. So really getting back to activity is important in most patients. Spines in general are more flexible. Healing time probably faster, and I think kids are able to heal from ligamentous injury in a way that maybe an adult may not be able to. So here's a case, 16-year-old MVC, L2 chance fracture. This patient was a soccer player and really was, wanting to get back to soccer. And in order to preserve motion, we utilized internal bracing with percutaneous pedicle screw placement. One specific factor I just wanted to highlight in kids is that the spines are just more mobile. So when you're placing a pedicle screw, there's more micromotion of the spine. So I prefer, at least in a percutaneous setting, biplane fluoroscopy for real-time feedback. I know that there are newer navigation systems and robots that I believe in the future will give you real-time feedback, but that requires exposure of the bony anatomy. So in an entirely percutaneous situation, I think it is helpful to have some sort of real-time feedback with fluoroscopy. So in this case, I typically, in kids, I think the number of levels is a little bit more restricted, trying to restrict one above, one below. Our patients are generally smaller and there's less stress on the screws. These screws are not staying in, forever. So we try to restrict the instrumentation just to the site of injury, and then ultimately remove the screws at 6 to 12 months. This has been well studied in the adults, as I'm sure you're, all familiar with, comparing percutaneous pedicle screw placement for internal bracing with the traditional arthrodesis and fusion. It's been shown to have less blood loss, shorter OR time, and similar functional outcomes. However, the pediatric data is limited. There's been several case series on the topic, but that's not been studied in a head-to-head fashion. There was a recent German study, sort of a national 6-center study, and of all patients with spine trauma, 153 patients, about 40% were surgical, and the majority, at least in Germany, they were treated with MIS. So I do think this is something that is increasing this role of internal bracing, but it hasn't been studied in a formal fashion. Advantages of internal bracing includes that it avoids a fusion, It provides more continuous stability than a brace would, and useful in patients who may be non-compliant with a brace, and then ultimately does preserve motion across the injury site, which is helpful. Arthrodesis is still helpful for cases of neurologic deficit needing decompression, and then addressing coronal alignment, which is harder to do, I think, with percutaneous pedicle screw placement. Here's another case, also a 16-year-old, a motor vehicle accident, multiple compression fractures resulting in, moderate to severe kyphosis at that level. The family and the patient really were not excited about surgery. And what I wanted to highlight here is that in kids, we're able to do, I think, a little bit more with bracing, just due to the spines being a little more flexible. This patient, of course, needs to be followed closely and is being followed closely because there is still residual kyphosis, but is doing well pain-free at this time. This is perhaps more of an extreme example of the amount of kyphosis we would accept in a bracing situation. We work closely with our orthotist, and I think that's important in pediatric cases. I think we've moved away from less casting and more 3D scans, and one of the things we'll do prior to the 3D scan is to make sure the spine is aligned and place a bolster in the area of the kyphosis. The braces tend to have longer trim lines. We're able to just be a little bit more aggressive in realigning the spine than we would be in an adult. Usually that requires an adjustment or two after the initial brace to sort of fine-tune the alignment. We use shoulder straps as well to help with realigning the spine. Typically, we'll brace about 3 months in kids. It really depends on the developmental status of the kid, the age, whether or not they're developmentally delayed, if they have sensory issues that can really play into logistics of bracing, the amount of ligamentous injury, as well as the amount of kyphosis that we're dealing with at baseline. In the setting of percutaneous screws for internal fixation, I occasionally add a brace for the first 4 to 6 weeks during that initial sort of healing process. I think it can be helpful. In the setting of percutaneous pedicle screws for internal bracing, typically remove the screws at 6 to 12 months, and then slowly increase activity after that time, and we'll get flexion extension x-rays to confirm there's no instability. I do find that in kids, really doesn't matter what you say, they're sort of going to do what they're going to do, and sometimes I'll, come back and the patient's gone from 0 to 60 all of a sudden, but we'll try to confirm there's no back pain and slowly increase activity after the screws are removed. So in conclusion, bracing may be an option in more pediatric cases with kyphosis just because the spines are more flexible and we're able to do more with the brace. Internal bracing can be used to preserve motion and avoid a fusion, as kids have decades and decades of time, and it's helpful not to be starting with a fusion at the age of 10, for instance. I think dynamic imaging, such as biplane fluoro, is helpful if you're not able to see the bony anatomy, just given the micromotion with kids' spines being a little more flexible with placement of the pedicle screws. Of course, more study is needed in the case of internal bracing in kids to sort of directly compare pedicle screw placement for internal fixation with the more traditional arthrodesis. So hopefully we'll have studies upcoming from there. Thank you very much. Please don't hesitate to reach out with any questions.